know me, my name's Erica. I am one of the R3s, and today I am going to teach a little bit about cirrhosis management for the medical resident. For those of you who know me, you know I really love cirrhosis. I love hepatology. I find the physiology really challenging, and I recognize that it's not everyone's cup of tea. So hopefully today I can give you some really basic, straightforward tips and tricks to try to make your lives easier when you are on the wards. Because we have a variety of learners, I want to start by getting everyone on the same page, reviewing a few definitions and some basic pathophysiology about chronic liver disease, and making sure that we all have a systematic way of assessing cirrhosis in our inpatients. I really want to try to make this palatable and manageable for everyone, and cirrhosis management in the hospital is really comprehensive. So rather than going over everything, I'm going to be really focusing on some common misconceptions in cirrhosis management and hopefully filling in some gaps in knowledge with some evidence-based practice so that you can say we are doing X plus Y, and not just because that's how my resident taught me when I was an intern. I have no conflicts of interest. And so I'm just going to jump into this. I think most of us have seen some kind of chart like this, looking at the progression of a normal, healthy liver all the way to end stage chronic liver disease, all the way up to HCC. This is particularly in the setting of NAFLD, but in all kinds of cirrhosis, you get some inciting inflammation or insult, which leads to fibrosis, that ultimately leads to scarring and cirrhosis. And I keep this slide in here just to remind everyone that cirrhosis is a pathologic diagnosis. And that's not to say that we diagnose all cirrhosis with pathology, but that is to say that cirrhosis is fundamentally an understanding of what you see under the microscope with scarring of the liver. And that's partly also to reinforce that you can have cirrhosis, you can have a really nodular liver on your CT, but that doesn't always correlate to what your liver is actually doing in terms of liver function. You can actually have up to 90% of your liver destroyed before you see clinical signs of liver failure. And that's really what I talk about when we get into decompensated cirrhosis. Now, when I was a medical student, this is really all I remember of cirrhosis, this creepy cirrhosis patient from step 1 and first aid. And it's a really confusing diagram. It incorporates everything, and it's really hard to understand what we mean by decompensated cirrhosis. And I think one of the things is that not all hepatologists agree on what sequelae should be included in the definition of decompensated cirrhosis. I would say that all hepatologists agree that once we reach this stage of decompensated cirrhosis, when your liver is no longer able to function and able to keep your body working normally, you have a really poor short-term survival on the order of like 3 to 5 years once you start getting some of these clinical signs. However, what pillars or facets or clinical signs are included in that initial diagnosis can vary. I would say that 80% of the professional societies incorporate 4 major pillars, and that's ascites, varices, encephalopathy, and jaundice. Some societies and some researchers will incorporate things like SBP or hepatorenal syndrome under this umbrella, but I would argue that those are really like an if then plus or minus thing. I would really focus when you think of decompensated cirrhosis of these 4 components. So before we jump into anything else, most of the pathophysiology underlying those clinical features can be really broken down into 3 components. And I think most of us, myself included, when I was learning cirrhosis, really focused on the first 2. And I want to, in this talk, hopefully shift some of your focus and your understanding of cirrhosis to incorporate this 3rd pillar. Just to review, the first one that I think everyone easily associates is with hepatocyte destruction and synthetic dysfunction. So when you start having 90% of your hepatocytes being shriveled and scarred down, you're no longer able to produce albumin or clotting factors to the same degree. That I think everyone can pretty much understand pretty clearly. The second component is portal hypertension. You are having all of your blood return from your gut and your spleen and your stomach being squeezed through an increasingly fibrotic and scarred tube, which causes backup and increase in pressure in those areas. And that classically leads to things like varices and ascites. But the third pillar, which I wasn't really aware of when I was in medical school and even in the early stages of residency, is the third component of inflammation and vascular endothelial injury. I think the cirrhosis causes a massive chronic inflammatory state, particularly in our decompensated patients who come in into the hospital with additional infections and other causes of inflammation. All of that together releases a massive amount of nitrous oxides, cytokines, PAMPs and DAMPs, if you guys are familiar with the immunology side of it, which causes some pretty extensive vasodilation where there shouldn't be vasodilation. And that causes a lot of the clinical signs and symptoms of cirrhosis, arguably in some cases more than we typically attribute to things like synthetic dysfunction. Before I drive through some of the rest of the things, I wanted to stop and make sure we have all our questions answered now that we have a kind of general playing field of what we consider decompensated cirrhosis. And I don't see the chat, so I'm going to have Kayla see if there's anything that we are coming up. Are we looking good? Awesome. So now that we have a playing field, I'm going to see what your experiences with cirrhosis. And this is going to be the first poll. When medicine triage pages and you have a patient in the ED with decompensated cirrhosis, what do you do? Are you just going to hide in the supply closet and pray that your senior pushes back appropriately? Are you going to just randomly jot down some things about varices? Or do you have a systematic way of doing things? Or do you just throw up your hands and consult hepatology in the morning? And hopefully we will have the poll answers come up. I'll leave it to Kayla to see when we need to close it. All right, so it clearly seems like most people have been on U-wards at some point, especially for our seniors who have been on U-wards sometimes twice over. So I'm not going to belabor the point too much, more than just to say that I really hope everyone develops some kind of systematic dot phrase or rubric in order to both take a history about cirrhosis and then ideally in your assessment and plan to be able to talk about the individual treatment plans for each one. Usually in mine, my personal dot phrase looks like something like this. It talks about the etiology, the severity, all of the features of decompensation, and then in the end stages of cirrhosis, looking like HCC, transplant status, particularly for those patients who are at UW and have been brought in from outside from Alaska to be worked up for transplant. This is a very, very comprehensive list. And it might be too comprehensive, especially for our more advanced learners who are going on to the hospital service and can do this in their sleep. But especially for the younger or earlier learners, I would really encourage people to think about this systematically. I'm going to include my own dot phrase at the end of this presentation for you guys with all of the different recommendations that I use to jog my memory. But because this is an exhaustive list and because cirrhosis is so complex, I'm going to go ahead and look at only a couple things and really dive into some of the misunderstandings and really kind of easy points of when we trip up, when we start looking at cirrhosis in the inpatient setting. The first of which is going to be about ascites and volume. So we're going to start with a second poll. For those who are, you have a patient who is finally coming up, your senior didn't push back successfully, and now you have a cirrhosis patient with 3+ pitting edema to the flanks. What is going to be your first point of action? Thinking. Hopefully we'll have some answers. Excellent. So I did make this a little bit tricky because although I would do probably 3 of the 4 top 3 of the 4 first ideas, I probably wouldn't give albumin as a first line agent. And I'm going to talk about that in a little bit. But before I do, I want to kind of explain a little bit as to why. So when we're talking about the pathogenesis of volume overload and ascites and cirrhosis, I think a lot of us think about albumin and the third spacing component that's driving a lot of this. But I would hopefully try to reorient some of your understanding towards thinking about that endothelial injury and that massive vasodilation you get with the nitrous oxide release in cirrhosis. All of that combined with some component of the low albumin causes the reduction in your effective arterial blood volume, and that triggers all of those compensating mechanisms like the renin-angiotensin-aldosterone system and your release of ADH to really put your nephrons into overdrive and try to resorb as much sodium as they possibly can. And because water follows sodium, you're going to have a pretty impressive volume overload. This is actually a diagram I took from an hyponatremia paper, but the physiology is the same. You're going to get a hypervolemic hyponatremia and massive volume overload. Now that we have the pathophysiology in mind, we can start talking about managing this. The first thing is because we're in this super sodium avid state, we want to try to start off with a salt deficit. And the classic meter is usually around 2 grams of sodium a day. If there's no salt for your kidney to hold on to, there's not going to be the water following it, and you're going to have an improvement in your overall volume state. To such an extent that in early non-refractory ascites, you can have about 10 to 20% of patients have resolution of their ascites with just salt restriction alone. However, I think most of us who have been at UW know that we are usually past that point when we get our really complex patients with cirrhosis. And that's the point at which we start thinking about diuretics. I've had a lot of people ask me and have a little bit of confusion as to why we use one diuretic over another. And I think most of us easily just reach for Lasix. It's what we're most familiar with. It generally has good effects in our heart failure patients with having them help out, pee out a lot of water. But I would encourage you to also include spironolactone, because we're really trying to get and hit at that distal nephron where all the renin-angiotensin system is activating to help with that sodium avid nature. Spironolactone is actually considered the first-line diuretic agent for cirrhosis as the aldosterone antagonist that it is. There have been a lot of studies that have looked at spironolactone versus Lasix or some combination, and the studies have all shown that spironolactone or a spironolactone combination should be your first line, and the most validated ratio is 40 to 100. So although I think that I wouldn't necessarily start spironolactone alone in a lot of our inpatient settings. Having it in combination has been shown to have a better outcome than just throwing on some Lasix. Okay. The last thing that I talk about, and I do this because we're in this volume and kind of hypervolemic hyponatremia state, is to talk about fluid restriction. And I really put through fluid restriction as a third line agent because we're really trying to tackle sodium retention before we tackle volume or water, excess water intake. Usually guidelines for hyponatremia in cirrhosis starts recommending fluid restriction once we get into that range of like 120 to 125. It's a pretty miserable thing to do to our patients, to make them to restrict their sodium to 2 grams and to restrict their water. So I have you guys think about this in balance with trying to promote their nutrition, because most cirrhotics do need around 3,500 calories a day to maintain an anabolic state. So trying to balance this predominantly with starting with sodium retention or restriction, followed by diuretics, should be your first line agent. Okay.
Erica, we've got a couple of questions in the chat before we move
Absolutely.
on. That last slide. So question from Luke, is that the ratio of Lasix to spironolactone for oral Lasix versus IV? And then a question as well, is it a ratio Spiro 100 to Lasix 40 rather than Spiro 40 to Lasix 100?
So it should be 40 of 100, yes, 100 of spironolactone and 40 of Lasix, and it should be, I believe, IV Lasix is my understanding. You can go all the way up to 160 of 400 of IV Lasix and 160 of spironolactone. So that is the correct ratio. Any other questions?
A couple more just popped in. Also curious if the Spiro Lasix evidence is in an outpatient population and we just extrapolate for inpatient, or if it's been looked at in an inpatient population.
To my knowledge, it has been looked at in the inpatient setting, but I can get back to you on that.
And then someone also is clarifying here, I think it's oral Lasix, just because I think the home regimen is usually 40 to 100. And I would agree with that. That's Gina said that I think that ratio is what's been studied initially for the oral in the outpatient setting. And then also a comment from Xavier, I feel like I had patients on a high protein diet as well. Is that universal or patient specific?
I think it would generally be universal. You do need quite a lot of protein to try to maintain that anabolic state. It's just a matter of trying to see what patients are actually going to eat. It's pretty hard to get them to adhere to any of these diets. Okay. The last thing that I talk about, because I think it's pretty common to get confused, is albumin. And when do we give it and why do we not? Albumin has a very low albumin in cirrhotics has a pretty poor prognosis. For every 1 gram per deciliter drop in serum albumin, you have a mortality increase at like 5 years of 137%. So we've been studying this since the 50s of like, well, if it has such a poor outcome, why don't we give some albumin back and see what happens? Increasingly, there is evidence to suggest that giving cirrhosis patients albumin does have a number of different benefits. The most recent and kind of most famous trial is the ANSWER study, which was done in Italy, published in 2018. And that was a study that took patients with non-refractory ascites and gave them IV albumin every like 2 to 4 weeks for 18 months. And they looked at a number of different outcomes, and this is just some of them that did show that it reduced the rate of SBP, of encephalopathy. It wasn't shown in this graph, but also in just general mortality. And that has been corroborated in a number of different studies throughout the years. The next question, though, is, well, if we are seeing all of these great studies, why are we not giving albumin more routinely in our cirrhosis patients? And that's predominantly because of the cost. The number needed to treat in the ANSWER trial was 9, but given the amount of albumin that they were giving and over the long period of time, that ends up costing somewhere in the range of $35,000 per patient. And I think that's both in terms of the cost of the actual albumin and also the setup time with the facilities, et cetera. Albumin I was always taught that it was expensive. And I actually asked our Harborview pharmacist to see how much it costs at Harborview. And so a 25-gram bottle at Harborview it costs around $85, which is actually a little bit less than I was anticipating. But we do still try, especially in the short-term inpatient setting, to limit our use to very specific circumstances. And that's because of a number of things. One of the things is that in cirrhosis, the rate of kind of extravasation of albumin from the intravascular space to the rest of the tissues is actually twice the rate of normal people. So when we give albumin in our cirrhotics, it doesn't always stick around that long enough to have a long-term benefit. The other thing that I think most people think about with albumin use in cirrhotics is using it to augment diuresis. And that has only really had mixed evidence. Some papers have shown a benefit, but it hasn't been borne out on repeated studies. And so I would really encourage people to, if you are having a hard time diuresing your cirrhosis patients, that's probably a sign that you should contact your neighborhood-friendly nephrologist to talk about alternative strategies. There are really only three data-driven indications and recommendations by the professional studies about when to give albumin on the inpatient setting. And that is for 1, large volume paracenteses, greater than 5 liters. You want to prevent fluid shifts. The second is for albumin challenges. And the third is for SBP. And that's actually shown to reduce the risk of hepatorenal syndrome in certain patients. I'm going to briefly pause before speeding through the rest. Okay. So going through a couple things, the next poll is about coagulopathy. You have a patient who has cirrhosis, but is actually coming in for community-acquired pneumonia. They have a white count, their anemia is kind of more in the inflammatory infectious setting, but their platelets are 57 and their INR is 3.1. It's 11 o'clock at night. You just need to throw in some admission orders. Are you going to start this patient on DVT prophylaxis? Lovely. So I think most of us clearly have some level of understanding about coagulopathy and cirrhosis. I'm going to, for time, I'm going to speed through some of this, but it's only just to say that the pathophysiology of coagulopathy and cirrhosis is really fascinating. And although we typically think of the low platelets and high INR as being really worrisome, there are always going to be a rebalancing of the bleeding and clotting dynamic in cirrhosis to the point where people, generally speaking, have a pretty balanced risk. At every level of the bleeding and clotting cascade, there is some component of rebalancing in the cirrhosis physiology. I wanted to talk about 2 points in particular. The first is for thrombocytopenia. And again, I'm not going to go through this too much because I think everyone has a pretty strong understanding of it. But most to say is that in my reading, which I was really surprised by, is that with patients with cirrhosis who have platelets even as low as 60,000, your thrombin formation is still appropriate. And that's partly because you have that endothelial injury, bringing that all back again. That massive inflammatory cascade actually counteracts a lot of the synthetic dysfunction that we typically associate with thrombocytopenia. The second point that I really want to emphasize briefly is to think about INR not as a risk or not as a good proxy of bleeding risk in cirrhosis. We really only think about it as a synthetic marker. There's no normalized standard reference equivalent for cirrhotics that we would typically to give the comparison of like a warfarin standard for your normal healthy populations. So INR really doesn't give a good proxy of bleeding risk. For those who are interested in reading more, there's actually something called thromboelastography, or TEG, which is something that's starting to get more and more used in the cirrhosis field. It was actually validated first in surgery and trauma cases, and it's a whole blood in vitro assay of clotting, and it actually measures both clot formation and breakdown, producing a chart that looks something like this, where the shape of the teardrop actually reflects the different derangements in the clotting cascade. Takes like 15 or 20 minutes to get a result, but it's not quite ready for IM prime time. Hepatologists are still debating about some of the reference standards and like how we interpret some of these graphs. Okay. Briefly pausing for questions. I'm not sure if I can see the chat, but anything else notable or interesting? Great. So the last thing I want to talk about is encephalopathy. For those of you who we've appropriately diuresed our patient, we've put them on a fluid restriction, but we're admitting them, we have them stick out their arms and they're flapping away. So what would be your first point of action to try to resolve their encephalopathy? Ooh, okay. So I want to, everyone who chose lactulose, which seems like the vast majority of people, are perfectly valid in choosing that. Lactulose has been our mainstay laxative for encephalopathy since it first came out in the 60s. And that's because when we've looked at lactulose, the actual mechanism of action, it has additional ammonia reducing mechanisms over some of our classic osmotic laxatives like Miralax or polyethylene glycol. And there have been a couple ways that we've seen this. First, of course, lactulose has its own component of osmotic diarrhea, but it also gets converted by the normal gut flora into organic acids, and that drops the overall pH of the colon, causing ammonia trapping to just further promote ammonia excretion. And that lower pH also favors urease negative bacteria, which don't generate as much ammonia as other colonic flora. There's also this third component, which is less understood, about reducing glutaminase dependent ammonia production, but I'm going to skip over that because we don't really understand how it works. That said, once we kind of discovered lactulose in the 60s, no one really took a moment to pause and actually do head-to-head comparisons. And I think a lot of people maybe who have been working in the with some of the hospitalist services, UW and Harborview, may be hearing something about the role of Miralax and how Miralax might actually be just as good as lactulose. Has anyone heard that?
I can speak, Erica.
Yeah.
I had Andrew White as an attending who had been a hospitalist for a really long time, and he felt like lactulose can be helpful, but patients hate lactulose and like Miralax more. And so the combination of not necessarily any evidence that one's better than the other, this is his words, plus better patient tolerance, maybe we should just be more heavy-handed on the Miralax.
Yeah. There is some emerging data in the last like 10 years that has actually shown that Miralax can have some benefits over lactulose in the role of encephalopathy. And it all usually stems, and most people will cite something called the HELP trial that was done out of UT Southwestern in 2014. It was a small trial. It was a single center. It only included 50 patients, but surprisingly, it got a pretty good statistical power. And it took the very straightforward intervention of looking at lactulose administration around 3 doses in the first 24 hours compared to Miralax. And I do want to say it was 4 liters of Miralax. And the outcomes that it looked for is a reduction in the HESA score, which is a objective score of encephalopathy. And it also looked at things like hospital stay and in-hospital mortality. And it showed that Miralax actually had a faster resolution of encephalopathy at the 24-hour mark. This table just reinforces that after 24 hours, the HESA score was much reduced is further reduced in the Miralax category. The other thing that it showed is that it shortened the overall time to resolution. It didn't show changes in length of hospital stay or a difference in mortality. But if you want to get someone to have a real improvement in their encephalopathy fast, Miralax might actually be better. The other interesting thing about this table, which which is really important to reinforce, is that the study also looked at ammonia levels and the ammonia level changes over time. And it showed that even though Miralax had a benefit in improving clinical outcomes of encephalopathy, it didn't actually change ammonia levels that much. And that's to just reinforce, and I hope most of you have actually heard this more than once, is that you should not trend ammonia in cirrhosis patients because ammonia is not correlative to clinical outcomes. This was, as I said, a very small study. It has been borne out by further studies and meta-analyses, which have confirmed that there is a benefit in Miralax in the inpatient setting in terms of reducing the clinical encephalopathy picture. Some of the limitations is that it didn't look at mixtures of Miralax and lactulose. Some people are doing combination therapy. They also didn't look at outpatient encephalopathy management. So I wouldn't necessarily say put all your outpatient cirrhosis patients on Miralax. But because, as Nikki was saying, patients really don't like the taste of lactulose. And if they prefer Miralax, which per this trial, it sounds like people were able to tolerate 4 liters of Miralax, which I find hard to believe. But if they tolerate it, the real goal is just to get them to poop early, poop often. The last thing that is just in terms of tips and tricks, and I really encourage you guys to, regardless of what laxative you choose, is to make sure you get it into them as fast as possible, especially as you're getting further along on that clinical encephalopathy course and they're no longer able to actively drink things. If you have any concerns that we're not making progress, you drop an NG tube as quick as you can. And whether that means to give lactulose or Miralax, you just need to make sure you get it in them. So anyway,
we've got some conversation and comments popping up in the chat here that I'll share. Absolutely. Some of. There's lots of surprise that 4 liters is tolerable because it seems like a lot of volume to everybody.
I agree.
Some people are saying this is sort of similar to colonoscopy prep, etc. Sarah let us know that at ACP this was discussed a lot. I had lots of questions about how to administer the lactulose, whether she use an NG tube, etc. Jordan is quoting from this paper for us. Patients are randomly assigned to receive 4 liters of PEG over 4 hours or lactulose, 3 or more doses of 20 to 30 grams over 24 hours. And then Lauren's wondering if Go Lightly or other bowel preps have been tested too. And Lauren, for what it's worth, Go Lightly and Miralax are the same chemical, just sort of different brand names and maybe different concentrations, but all polyethylene glycol.
Yeah.
I think I captured just about everything.
Yes, so I totally agree. I'm not sure who talked about the volume of the Miralax that we're giving is, I think, it was very surprising to me. And per the discussion from the authors of this paper and in subsequent papers, people seem to be tolerating 4 liters of Miralax either through NG tube or orally better. It's like a saltier taste, which people prefer. I don't honestly know if I could tolerate 4 liters of any volume that quickly, but it is a good reminder to those of us who may be hearing some of these discussions about Miralax as a better encephalopathy agent than lactulose, to really remember that when we give Miralax in the hospital, we're doing like a single 17-gram packet in like an 8 or 12 ounce glass of water, which is pretty drastically different than what the power of lactulose is.
Also some questions coming out about how we volume restrict if we're giving them 4 liters, but then also some thoughts about that polyethylene glycol is supposed to be isoosmotic, so maybe that helps with the problem.
Yeah, so they did talk about volume and dehydration as being a concern with the sheer amount of Miralax or that you're giving them. And in terms of the outcomes, they didn't actually show that you had significant electrolyte shifts or significant volume derangements when you're given that much that quickly.
And another question just popped up from Nick. Erica, I know GI docs have told me large varices or unknown variceal status is a contraindication to placing an NG tube, which can make enteral access challenging and altered patients that have to rely on rectal lactulose. Any comments or thoughts about the situation?
Yeah, I think it's always why like trying to get a history either from patient or chart review is always helpful. I think typically with large, like if you don't know the status, and again, I don't have clinical evidence to back this up, but in my general practice, I would say like I would still place an G-tube in most of the cirrhotics because of the just the general benefit. If you're so encephalopathic that you can no longer protect your airway, the risk of having infections and other complications can be really big. In terms of rectal lactulose is pretty suboptimal for a number of reasons. One, you have to have most nurses, just to physically get it in them, need to have some sort of rectal tube in place to facilitate the administration and the subsequent output. The other thing about rectal lactulose is that most of the time with any kind of enema or suppository, you want to be able to keep it in there for a certain amount of time. And most patients who are getting rectal lactulose, if they're that encephalopathic, don't really have the ability to work with nurses about retaining that for a little bit of time before they let it pass. So typically I go oral access for lactulose is always better in my general experience. But admittedly, I agree you're always going to get in some of these patients between a rock and a hard place.
And Erica, one more question I have myself while we have you.
Yeah.
I'm curious if they, in this HELP study, if they somehow quantitated stool output, number of bowel movements or volume of stool, because I also wondered, this is a lot, like you think about the amount of stool someone is having with a bowel prep for a colonoscopy, which is a similar amount of polyethylene glycol. That seems like more than the number we're often titrating to with this amount of lactulose.
Yeah, and so they didn't quantify the amount of stool, but I would encourage people, in terms of, that's a good point you bring up in terms of how much stool and what are we titrating to. And I think the classic recommendations that we see from our GI colleagues is like 3 to 5 bowel movements per day. And for me, I will say that's all well and good. That helps the nurses being able to quantify number of bowel movements. However, it really should be to mental status. And I think in a lot of these patients who we are really trying to aggressively treat their encephalopathy, as much as we give the nurses that 3 to 5, as clinicians, we should really be working on looking at assessing their mental status and assessing their hepatic encephalopathy from a clinical perspective and pushing that lactulose fast or Miralax. Awesome. So some takeaway points. One is just always remember that component of the inflammation and endothelial injury. I think that is almost more than anything else between that and portal hypertension. Those are the two main pillars that are driving a lot of the sequelae of cirrhosis pathophysiology. Always use a systematic framework in assessing your sequelae of decompensation. Albumin does have mortality benefits but it was really only approved in certain circumstances. Coagulation panels are not a good reflective bleeding risk for our cirrhosis patients. And in encephalopathy, the type of laxative increasingly is less important than getting them to poop early and often. So I did promise while we're asking any further questions that this is my dot phrase that I use. It incorporates a lot of the basic general recommendations for cirrhosis that I use to remind myself at the very least of what we should be getting in at 11 o'clock at night. And then we think about, you can look up some of the more detailed guidelines in your own time. But I hope this is helpful. I hope it wasn't too broad or too general, but I think that knowing why we do certain things with cirrhosis, more than just because we learned that in intern year, is often helpful.
I have one question if we have time.
Yeah.
When you're admitting somebody with cirrhosis and you want to decide whether or not they have ascites to tap, because obviously that's going to influence your approach in determining SBP or not. Are you content with like your own POCUS in finding a pocket, or would you always push for like a more thorough imaging modality like CT scan or formal echo, or not echo, but ultrasound?
Yeah, I would always encourage you guys when you're admitting someone is to go into the ED or wherever you have and do your own POCUS. It will give you a lot of self-confidence in your ultrasound skills, because I would argue that looking for pockets of cirrhosis of ascites is probably the easiest ultrasound exam that we can do. A lot easier than getting your parasternal longs. Getting any sort of like sticking any sort of probe, typically we use the cardiac probe on the belly, looking for pockets, because if you're going to be tapping them, you need at least typically safely 5 centimeters of depth of any one of those pockets to do it at bedside. So when I'm diagnosing ascites, it's not just to say, oh, they have it, but also looking to see if I have the skills to tap that pocket.
And Erica, one other question in the chat, Sylvia asking if there's any difference in ammonia levels in acute liver failure versus cirrhosis. And I'm imagining she means difference in the importance of ammonia levels, Sylvia,
Yes.
if that's right.
Yeah, so just to reinforce that point, for someone who has a chronic liver disease and chronic cirrhosis, ammonia levels are not correlative to clinical encephalopathy. That is a very different ballgame for acute liver failure, for people with Tylenol intoxications or acute alcoholic hepatitis. There are those, in those instances, ammonia does correlate and it should be trended.
I have a question too, Erica.
Yeah, go ahead, Gina.
Last one. This is maybe sort of like another step up with like the coagulopathy, but I feel like when I've taken care of cirrhotic patients with cirrhosis, like when they've bled, we've gotten like a DIC panel. And I think getting a DIC panel in patients with cirrhosis is so hard because their fibrinogen is usually low, their D-dimer is usually high. And we usually don't do anything about it anyways, because you're not going to like give them FFP because they're still clotty. And so like, did you read anything about that? Like, should we even be getting like DIC panels in these patients? Like, is there any use to that at all?
Yeah, I think that typically, I haven't seen any or read specifically about DIC panels in cirrhosis, but I would argue that in most cases, especially on the floor or even in the ICU, most of the cirrhosis patients where we need to be concerned about coagulopathies in terms of bleeding risk will declare themselves. Unfortunately, that's the case. Like if they're bleeding from their varices or other reasons, then we should start thinking about how we treat it. But if we're just having a run-of-the-mill patient with cirrhosis who doesn't have any active signs of bleeding, the DIC panel usually wouldn't have that much of an impact. It wouldn't change management.
Awesome. Thank you.
And that's just to say, just to run up with coagulopathy, I think people tend to get confused about transfusion levels for cirrhotic patients. And again, unless they have active sequelae of bleeding, I typically avoid transfusions just to like reach a certain threshold, because cirrhosis patients are at much higher risk of transfusion complications in terms of things like volume overload, which can often cause more harm than good.
Gina, for what it's worth, I will share the other times that I have ordered DIC panels in patients with cirrhosis are patients who suddenly have a precipitous change. Someone who suddenly has a platelet that goes from low-ish to very, very low when you're worried there's a secondary process going on. It is complicated because patients with cirrhosis tend to have a coagulation panel that looks like DIC when they are not in DIC, because you're exactly right, like the precision is low. So it's complicated. I've ended up then needing to consult hematology to help me clarify, and they think I'm a dummy, but otherwise, I think not super high yield unless you have a clinical change. Cool. Well, maybe if anybody has last trickling questions in, Erica can hang out, but why don't we take a break and plan to come back at 9:55 for our next talk?